Okay, so welcome back to the PainExam podcast. We're joined with Amy Baxter, pain management researcher and pediatric ER doctor. Welcome, Amy.
Thank you so much for having me.
So you've been up to a lot of things. We connected a while ago, and we were recently put in touch with someone else. You're very involved in pain management, especially for children. I think your research is. Can you tell us a little bit about it?
Sure. Well, initially, my research was needle pain management for children and got funded by the NIH to develop a mechanical stimulation device for needles. And about 4 years ago, one of my colleagues turns out was in opioid recovery, and he used the device to not take any opioids after a total knee replacement. So that was really the catalyst for stopping practicing in the pediatric emergency department, getting an NIH grant with NIDA for adult low back pain, and really digging into the mechanisms of gait control that have been discovered in the last 5 years.
And how does the device work? It uses vibration?
Sure. Well, all our basic devices are Buzzies for needle pain and VibraCools for knee pain. And it's exactly the same device because the frequency is about 200 hertz. So it's not, it turns out, the vibration that makes a difference. It's what frequency you're stimulating. So about 5 years ago, 2017, Dan Hollins published a paper demonstrating that the Pacinian corpuscle was the one that was overwhelmingly responsible for pain relief. So of the large afferents, the Ruffinian and the Merkel discs and the Messner corpuscles, the Pacinian does position sense. So it makes sense that it needs to be exquisitely sensitive to frequency. And indeed, turns out about 180 to 250 hertz is the sweet spot if you want to stimulate the Pacinian corpuscle, and for our purposes, use that to then block pain. So this is really, to me, kind of a Rosetta Stone for why things like TENS units have been iffy. Because if the way that a TENS unit works is to stimulate the Pacinian, well, they're the deepest corpuscles. So if you got a layer of subcutaneous fat, you're not going to be getting in deep enough unless you jack up the amplitude. It also explains a lot of times the TENS units are only used about 160, 120 to 160. So they're a little too slow to optimally hit the Pacinian. And the final cool thing by Guang et al. Was that mechanical stimulation passes in a wave. So as the wave decays, we'll start with the 200 hertz, but then as it penetrates, it fans out in a wave that slows down and mops up all those slower frequencies. Like Messner corpuscles are 2 to 5 hertz. So that's in a nutshell what I've been putting together. And so there's a bunch of other really wonky stuff with 1A afferents and interesting stuff with prolonged exposure. What we're looking at right now with my grant is if we can mix and match a bunch of different frequencies and patterns to try to get a really prolonged pain relief, like 24 hours.
How deep can you get? Let's say somebody has a facet problem or a sciatica. How deep do you think your waves can penetrate to actually target those inflamed areas?
Sure. Well, of course, that's more of an amplitude rather than a frequency issue. And right now, we're having no problems getting down about 3 inches. So it really is somewhat dependent. And that's with a 0.1 meter per second squared amplitude. So we could get that higher. But one interesting thing is you really have to mix and match different motors and flywheels to get to the place where you're getting the stimulation that you need. It also really makes a difference what orientation you have, because the torque has to be perpendicular to the pain nerves to really blanket out the A deltas and stop them, rather than, you can't use a cell phone. People are always like, ooh, could I just use my cell phone? Well, no, because it's a coin motor that's spinning perpendicular to the skin. So I told you, this is wonky. This is really
yeah. I mean, years ago we spoke about Ouchie, right? Or Buzzy, excuse me, Buzzy. And this is different. This is like the next generation, more or less.
Yeah. Well, it's, I feel so much better because I understand now why it works. And so that makes it easier to manipulate for different purposes. Before it was, everybody was calling it distraction. And we knew it
Right.
wasn't distraction because if the battery started wearing out and the frequency got too slow, it was very binary that it quit working. It quit being effective. But some of the things we're finding out is that it really does depend on what tissues you're applying the stimulation to, because bones are great. Vibration and mechanical stimulation transmits beautifully in bone. So if you're on a hip, on a joint, the SI joint in particular is one place where if you get an entrapped nerve, like say you really should be getting some kind of fixation because you've got a loose SI joint. So putting the 200 hertz on it is immediately restorative, immediately being like a minute. I mean, it goes away. It's really quick because it's mechanical and it's on bone. But it does not work as well for soft tissue. So it's really good around shoulders. It's really good around knees. It's good on back. So any place where there's a lot of Pacinian corpuscles.
It's funny. I would have thought it would be better for soft tissue, but okay.
Yeah, it's not. It's because position sense nerves are clustered around the joints, right? So
right.
And it's still good for well, this is another interesting thing. So much slower frequencies like 60 to 90 hertz are good for recovery and delayed onset muscle soreness. And what's happening there is that you're separating out the muscle fibers that may be joined with lactic acid. So if it's a tendinitis, if it's some kind of encephalopathy, then using a slower frequency can separate those to improve blood flow and get that done. But high frequency is better for vasodilation. So one thing that's happening right now is they're using Buzzy in the hospitals that have them for COVID vaccination, because they're tenderizing the muscles, separating the fibers so it doesn't get so sore the next day, and then using the fast part if they tend to vasovagal, because we're using a sympathetic stimulator with Buzzy and high frequency, and it blocks the parasympathetic vasovagal response.
Has anyone used it for interventional pain procedures?
I mean, depends on what kind of interventional. It's used a lot for blocks, but more for distal blocks. So like there's some podiatrists who used it for blocks in the foot. Compared to cold spray, it was twice as effective. Again, it's going to be good on bony prominences. I don't think it'd be as good. Well, on digital blocks, it's obviously really good for that. And so that.
What about neuropathy? Diabetic neuropathy? Has anyone used it for that?
They have tried, but I don't think it'll work for that. And we haven't seen good results because it really only works for healthy nerves that are behaving normally. If you're manipulating the normal behavior of nerves, for post-surgical, for example, it decreased opioid use 35% for ACL reconstruction.
Oh, wow.
So if you're using it for normal nerves behaving normally, it doesn't matter what the source is of the sharp pain, whether it's a procedure or it's an injury or it's inflammation. But if it's something where the nerve itself is damaged, like shingles or neuropathy, then it's not going to work. Probably makes it hurt more. Wow.
Okay. So you're doing, not just developing the product, you're also doing research in this. You received a grant, you mentioned. So lots happened since we spoke. Wow, it's fantastic. Where are you located?
I'm still in Atlanta, near Emory, just a little south, your old stomping grounds. Nice. And I'm not doing what I have discovered is that when you go full-time CEO of a small business, it is extraordinarily difficult for anybody to take your research credentials seriously, because everyone assumes there's conflict of interest, because there almost always is. And in fact, I'm sure there would be if I were doing some of this. So all I'm doing is the NIH trials for low back pain, and everything else is being done independently. So it's either, a random fellow who's got a research project they have to do, because the effect size is like 0.6 to 0.7. So it's a really easy way for somebody to do a quick study with 30 people and find something publishable.
Got it.
There's over 50 randomized controlled trials now, and all of them are independent, and we didn't pay anything. And usually I try to avoid giving away freebies because I'm cheap, but it's a reusable device, which is one of the things that from a business standpoint, I'm still extremely proud as a physician that we have not capitulated to making it disposable just because we can, or to make a buck, or doing a subscription service, or any of that other stuff that's just not why I quit practicing. I don't want to hurt the patients who are in pain. At the
Sure.
same time, you know, we are trying to grow as a company. I'm not trying to fail. So it's this delicate balance of, you know, how much stuff do we give away for free, and how do you parse that so you make people realize it while still being a concern that can attract good people to work with.
Sure. I wonder how it would do on a cluneal nerve entrapment, because you have a nerve that's right by a fiber osseous tunnel, so that's right by a bone. It's being entrapped by a tunnel right on top of a bone, the iliac crest. So I'm wondering how that would hold up. That'd be very interesting to see.
Huh. I mean,
I see
the
where,
iliac crest might be superficial enough that it could work.
yeah,
It's about 50-50 on pinched nerves in the neck. It really depends on how superficial it is. So if you've got, you know, if you move in one direction and all of a sudden you get the C5, C6 tingling, you can put it on and then that can resolve. But I'm not sure. It depends on how much subcu fat there would be on the iliac crest. It's probably easier than the SI joint, to be honest.
Yeah, it might be. Is it a sticker, or it's just you put it on, you hold it
Oh,
there?
no, it's, I mean, it's big, it's physical. It's so, what you're looking at is a 1 inch by 2 inch by 3.5 inch device. And this is the frequency.
Oh, wow.
Yeah, it's,
I think I'm deaf. Okay.
That's the magic. But we do, I mean, most of them, that one's on my desk because it's unacceptably loud and I've been playing with it. But
And there's no code for coverage yet, right? The insurance doesn't cover that yet.
No, it's frustrating. They explicitly said they would never pay for Buzzy because needle pain doesn't matter and is not part of their mandate. Because you have to have stuff that's good for older people. So now that we have opioid reduction for oral surgery in seniors and the ACL, the ACL reconstruction thing was interesting because the guy that did the study was trying to do opioid reduction through coaching. And so the normal ACL 25 Percocet, he got people down to 15 Percocet with coaching. And
wow.
The VibraCool group only used 10. And they didn't have any coaching. It was just the VibraCool. And so he wouldn't publish it. So we're actually talking to a group in Anchorage about trying to replicate that. But it was 14 people, you know, it's not, again, big effect size. So we're working with groups in DC right now to try to present this to the DME groups with the Centers for Medicaid and Medicare, because when the one study, guy who is the editor of Practical Pain Management. So he just out of the goodness of his heart, he decided to try it against his 10s. He did a randomized crossover trial and it was about 2 times better than 10s for osteoarthritis, but that's the poster behind my head, but it was on average 2.2 centimeters more pain relief than 10s, with 95% confidence interval of relieving pain 2.85 centimeters to 1.55 on a visual analog scale, P less than 0.0001, which is great, except for he didn't go through an IRB, and so that's not publishable either.
Of course. So are you selling the devices on your website now, or they're like, how does it work if someone wanted it? Is it ready to be sold and used, or is just using research or whatnot?
Yeah, so VibraCool and Buzzy are both on the paincarelabs.com websites. They're on Amazon. They're available through the FSA and HSA. We are FDA 510K cleared to control needle pain, and we're 510K cleared to treat pain from muscle restriction or muscle tension. So we're pretty broad in that way.
That's great.
You know, no, go ahead. I got him.
I was going to say, what if okay, so my staff prepares a patient for an epidural steroid injection. What if I had my staff leave it on their back buzzing while they're waiting for me to do my paperwork? So for a few minutes, they're having buzzing right over the needle stick site, and then I remove it, clean the back, and do my shot. Do you think it would reduce pain prior to injection? So
with port access, what we do is combine the vibration frequency with ice, because you can invoke descending inhibitory noxious control if you leave the ice on for about a minute. So if somebody has got a port, they will leave the vibration and ice in place for about a minute, and then it'll stay numb for about 30 seconds to 45
That's
seconds.
great.
So, but what they're doing in France, actually, because they do a lot of their LPs in kids who are awake, just using a little bit of nitrous. So there's actually a video online using Buzzy proximally and leaving it on the spine, just out of the sterile
Right,
window.
above the area. That makes sense.
Yeah, it has to be between the brain and the pain, or directly on the pain. So
Okay.
if you're, and the thing is, you know, like Buzzy's like $40 and VibraCool is about $69.95, so about 70. So they're very inexpensive, but we also recommend that people use them if they're using them at home. We've got hot or cold, because one of the things that I've really become impressed with, as you probably have as well in the last 10 years, is just how much catastrophizing and fear and lack of control pay into pain management.
Of course.
So one of the nice things about something that is instantly activatable is that it gives the patient control, and it also, if you allow them to use or encourage using ice or heat, I did the calculations for thermal energy to make sure that we can't give frostbite to anybody. It's going to melt before then, but it freezes solid, so it transmits the vibration unimpeded, so you're still getting that frequency, and you also get the descending inhibitory control, you get the anti-inflammatory effects of ice, and because of the vasodilation, it's still, you're not impeding the blood flow for a short period of time that you're using it.
Right. Wow. That's fantastic. It's a whole science to this. I mean, I knew the basics from board review and training, but that's fantastic.
It's new. I mean, to be honest, none of this stuff really came out. The big thing that made me have a usual suspects moment was a book by this Italian guy named Sagini that came out December of 2018. And it is the most heavily referenced book on mechanical stimulation and nerves, and, you know, large fiber, A beta, 1A afferents, just really putting it together in a comprehensive picture. But most of the stuff they're referencing didn't get published until 2010 and after.
Wow. That's great. So, okay, so if someone wants to find you or your products, you said Amazon, it's Buzzy and VibraCool?
And VibraCool. Pain Care Labs is the place where we put all of the information about the science and gate control and all of the bibliographies. So if anybody wants to do their own study, they can upload the bibliography with all of the PubMed ID numbers, so that it's easy to go through with that. I also keep a running tally. If it hasn't been put up on clinicaltrials.gov yet, but somebody is thinking about doing a study, contact me, because I don't want anybody to replicate something and then get scooped. So it's
Right.
But it's a Baxter at paincarelabs.com, and I'm just thrilled to talk to you. I'm kind of curious about what you're doing that's new, or how practice has changed for you in the last few years.
In the last few years, I'd say the big change was I started to believe in regenerative medicine. At first, I wasn't sure if it was something just to make money or if it was something that really worked. And I'm seeing that it really works and it's safe. Especially PRP, bone marrow aspirate, have been a lot of good success with that, and peripheral neuromodulation. That's really a big thing I've been doing a lot lately. Very safe, no implantable batteries. All the batteries are external, so it's really implantable aspect of the procedure is a lot less than a spinal cord stimulator, for instance. And aside from keep creating on the podcast and PainExam, the ultrasound has been taking up a lot of my time, and love to teach, love ultrasound. So it's been growing on its own.
That's pretty cool. Do you know the work of Robert Odell, who's using some electrical stimulation for peripheral neuropathies?
I know his name. I can't think of how or why exactly at this moment, but yes, I'm familiar with his name, and I probably read something of his.
Okay, yeah, just again, sort of regenerative. I think that there are going to be so many new therapies with energy modulation. You know, if you think about the cellular structure of that all cells have these integrins on them. They've got, you know, essentially shock absorbers that are designed to feel and respond to in an anabolic way. to grow with response to mild stress. And so it makes sense that a lot of these energy therapies, whether you're doing it in nanometers or in hertz or in more gross massage type oriented energies, it does make sense that there's regeneration and growth, because that's what the body is designed to do, is grow in response to minor stresses.
Well, I had a patient I did peripheral neuromodulation on for facet problems in his back, and he came twice a year for shots, and he did great. He was a very good responder. The first time I did a peripheral nerve trial on him, I did the medial branch nerve in the office, and 15 minutes of stimulation, he got off the table. He said, "That was the best thing you ever gave me." I went on to implant him, and he's happier than ever. I might not see him as often now, but that's okay.
Well, and that's a nice thing actually about physicians. I've also really worked with a lot of chiropractors and PTs since going off the reservation and talking about energy therapies. And we really, I think, like to fix things. I think that we're like, fix it once, whereas we don't have the patience necessarily of a PT to go over and over, and we don't necessarily have the desire for a relationship for a chiropractor who's doing a little bit of psychotherapy at the same time.
Right.
And so I'm to have somebody who gets totally fixed on once or twice, I think that's the highest joy, isn't it? To really change somebody's life with just a quick intervention.
100%. And you mentioned you're an emergency room doctor, correct?
Right.
Yes. Yeah. So do have a course February 7th of ultrasound guided interventions. I'm specifically focusing on EM physicians, because I think there's a big utility for safe and quick, effective nerve blocks in the ED to get people discharged, especially with COVID hanging out. I think most people don't really want to spend any more time there than they do already. So,
nerve blocks are such the power in the emergency room. It's a flex. If you can pull off a nerve block in the ED, you're a god. It's so cool when you can do that.
That's right. That's right. And ER docs are pretty quick learners with this stuff. I know they get excited about using ultrasound to do all sorts of things. So I think it's going to be a good mix. Anyway, I do need to wrap it up. I want to thank you for joining us. I'll put your links on the show notes, so anyone who's interested, they could find you. And thanks for your time.
You are so welcome. And I really appreciate being able to talk some science with you.
Yeah, it's great reconnecting. Take care.
Thank you again.